UG and PG examiners in many universities. Welcome to you both, sir. Our moderator for today, Dr. Bala Guhan, who's going to take ask questions to our mentors. He's Professor and HOD of Department of Oral and Maxillofacial Surgery, Karpaha Vinaya Institute of Health Sciences. He completed his master's from SRMC and went on to do his fellowship in cranio-maxillofacial surgery from Shaw Mazumdar Cancer Center, Narayana Hridalaya, Bangalore, and is also a fellow of the Indian and International Board for the Certification Specialists in Oral and Maxillofacial Surgery. His areas of special interest are cleft oncology and TMJ surgeries. He is member of various academic associations. Welcome to you, sir. So we'll first start with the TMJ surgery session. I kindly request all the participants to mute your audio and video. I kindly request participants to mute your audio and video. After the mentors finish with your PowerPoint presentation, both the mentors, you will have a 5 to 7 minutes question time in which we will be sharing you a link and you need to answer those questions. Any other questions in the course of the session can be posted on the chat box in Zoom and also in your YouTube. Over to Dr. Bala Guhan, sir.
Bala, you are muted. Bala, you are muted.
Bala, not
Yes,
able to hear you.
Sir, now you can hear me, sir.
Yeah, I can hear. Yeah, now it's okay.
Today, our first presentation about temporomandibular joint disorders by Dr. Muthushekhar, sir, will be going through the presentation now. Sir, the first question is, the prosthesis or alloplastic material available for temporomandibular joint replacement and their indications, advantages, disadvantages, as well as complications, sir. It's both inclusive of short-term as well as long-term, sir.
The prosthesis available now at present is cobalt, chromium, molybdenum composition alloy with titanium alloy also coated. So that there are two systems which are very popular. One is the US FDA system, which is custom made. I mean, it is ready-made. They have three sizes. So you have to select one among that according to your CT scan and your 3D models. But the other one is the Christensen system, which is again, it is custom made according to the patient requirement. So that is a better thing. But again, that on the medial side of the custom made, they have the titanium plasma coated, so which has got a very good osseointegration. And maybe we have just done one case in our institute, which we found it very useful and good also. But if you take the history, they have started with tantalum, 1946, they have started with tantalum, and so many other materials have been tried and they have been coming. And for the fossa component, again, Proplast was being used before, but now it is ultra high molecular weight polyethylene, which is again, it's supposed to be good and it is quite biocompatible and it withstands very well. So, but anyhow, we have to wait and watch, see that because it's being done off late only, maybe for the last few years, it has been become very popular in Chennai. Many of us have started doing it. Many of my other colleagues also are doing it. So we have to wait and watch. But it is compared to the other costochondral junction and on an adult patient, it is quite a good proportion to use ready-made joints. Advantage, again, one is the advantage, it has got lack of donor morbidity is there and good occlusal stability. No need for intermacular fixation like how you do a costochondral graft where you have to do an IMO for some time. And early range of motion, dietary improvement also is good. Decreased risk of ankylosis from heterotopic bone formation and decreased surgical time. These are the few advantages are there. The disadvantages, a major disadvantage is only the cost factor. One of the main thing is the cost factor, and it's very highly technical sensitive unless you prepare your models very well and the models for 3D models, and then you get a good MRI, a CT scan, and plan it very well and then do it, yes, it will be a good proportion.
So these are the materials for use for.
Yeah, according to the old history, I mean, if you see the 1965, they started from that time, so many different materials have been used. But now the material is of the cobalt, chromium, molybdenum. That was the material. And the inner portion of the ramus portion side, they use a plasma coating of titanium so that it will have a very good osseointegration. And for that, condylar fossa, it is the
Ultramolecular,
yeah, polyethylene.
Yes.
That is again, that also has got a little metal inside titanium. Over it, it is coated.
Yes, yes, sir. Going to the next question, sir.
The same thing is already I have completed. What is
Yes, sir. Yes, sir. Yes, sir. The TMJ ankylosis, sir. The treatment algorithm, whether the empirical treatment algorithm, like we have to do a gap arthroplasty, or the newer treatment methods, whether we have to start with the distraction osteogenesis first, sir.
Now, if it is going to be an adult patient, and if it is the first time you are going to operate and he has got a severe deformity, which has been for many years he has not got treated, has got a deformity, then it's always better to do a distraction osteogenesis first, and then once you get the correct the mandibular length and his aesthetics, then you can do the gap arthroplasty. But if it's going to be a young child, maybe 4 years, 5 years, then first thing is you have to do a gap arthroplasty, then a costochondral graft, wait for the growth to settle, and then if required, you have to go for orthognathic surgery after they're 18 years old. But for an adult patient, young adult patient who has got severe deformity, got respiratory distress, obstructive sleep apnea, and other complications, better to do the distraction first and then do the gap arthroplasty, or maybe now of late again you can do a TMJ replacement. If you want, you can do a TMJ replacement. The patient is affording and you are able to get a TMJ joint for the patient, you can best to use a TMJ replacement.
Got it, sir. Sir, clinically, how do we assess disc displacement with or without reduction, sir, in TMJ internal derangement?
No, disc displacement, yes, first thing is, if it is displacement with reduction, always the first initially there will be a slight shift to the mandible on the affected side, then the click will occur, then this mandible will start moving normally, almost they come to the normal side, the midline will be matching, and then they'll be able to open the mouth normally. But initially they'll have a slight shift to the affected side always. But if it is going to be without reduction, first thing is severe pain. Patient will have severe pain, tenderness over the joint, as well as patient complaint will be more of pain, and then it will be restricted mouth opening. And even after a few millimeters, it will not, even if you try to force it, it will not open. And patient will have severe pain. That is one, clinically, that is a sign where the pain with restricted mouth opening, it's usually without reduction. But if there is a slight shift, and then the patient is able to, with a click, after that, they are able to open the mouth, then it means there is with reduction. It has got reduced, disc has got reduced, so he is able to open the mouth normally. But if it is going to be without reduction, restricted movement, very severe restricted movement, pain, tenderness over the joint, as well as patient will have severe pain on the side which has got locked.
So you are coming to say the deviation, pain, as well as the noise. All these symptoms for clinical assessment for TMJ.
Yes, that clinical assessment is the three things: pain, shift to the mandible, then the clicking noise.
Yes, got it.
But if it is above that, after that the reduction, if suppose there is a disc has been perforated, then this clicking noise will become a crepitus, and the patient will not have that much of pain, and they'll be able to open, but it will have a lot of crepitus. That is one sign to see that it has gone beyond conservative management. You have to go for a surgical management.
Got it, sir. So the TMJ arthroscopy indications, techniques,
Arthroscopy is mainly for just to, for main thing, see the joint. First thing, arthroscopy is very good to see the intra-articular surface of the joint. When there is some problem, patient has got particularly displacement or some difficulty in opening the mouth or crepitus, or they have locked, then the best is to, you can visualize the joint. For that, you
Yes.
use only a single needle to visualize. You need a single needle. But if you want to do some treatment like correction, then you have to use multiple needles, which will use accessories are there available, so you can do the thing. And the arthroscopy is mainly to see for the disc displacement and then disc deformity, intra-articular adhesions, degenerative arthritis, to visualize this. And if you want to have arthroscopic and lavage, again, it is very good to go a lavage. Arthrosynthesis, again, lavage, where you can release a fibrous adhesion with that. You can see that them getting relieved. But if you have to do surgery, yes, you have to use the multiple needles, and it is again very highly technically sensitive thing. You need a real good training to start doing surgical management of through arthroscopy.
Okay, sir. Okay, sir. Sir, is there any difference between the conventional way of doing arthroscopic lavage and TMJ arthroscopic lavage with the arthroscopy, sir? Is there any difference, sir? Or the success rate is going to be same, sir?
No, that's what I said. No, the regular arthrosynthesis, what we do is blindly we do it. Just by anatomical landmarks, you try to go into the joint and upper joint compartment and try to release adhesion by trying to inflate your finger lactate solution. But if you are doing a lavage, arthroscopy lavage, then you are seeing the joint, you are able to clear it with your instrument, the needle itself, and then wash the joint very nicely. So definitely there is better advantage of doing an arthroscopic lavage.
Yes, sir. So the protocol for management of temporomandibular joint ankylosis and how coronoid process and antigonial notch become prominent in TMJ ankylosis, sir?
Again, the protocol for management ankylosis again depends on the, as I already told you, depends on the age of the patient. Young patient, gap arthroplasty, and then costochondral graft. Growing child, it's going to be a growing child costochondral graft so that the condyle length will be maintained. But if it is an adult patient, gap arthroplasty, nowadays we don't do a temporalis flap or a temporalis fascia, because in my few years I've been doing dermis fat graft, and that works really well. I mean, it is much better than it doesn't have a re-ankylosis, or there is a movement is much better than putting a temporalis flap, where I've seen the temporalis flap sometimes when you reopen, you don't see the temporalis muscle what you have interposed in the joint itself, because it has got atrophied because of maybe avascularity or a necrosis. The muscle would have got atrophied, and again they go for a re-ankylose. Whereas the dermid fat, it has been proved with MRI that it has get vascularized after some months, and then it remains there for a longer time. So the re-ankylosis is very less. The movement of the joint also is good. Again, the protocol is same thing like Kaban's protocol. What you say is on the table you get a mouth opening of 35 to 40 millimeters. If it is not there, do a coronoidectomy on the same side, or if you still the mouth opening is not improved, to do on the opposite side, and get a mouth opening on the table up to 40 millimeters.
Yes. And the coronoid process and the antigonial notch become prominent.
And that is mainly because of the two different group of muscles are acting. One is the masseter and temporalis acting on the ramus, and the depressor group of muscle acting on the body of the mandible. So that, and all the time the patient is trying to open the mouth forcefully, and so that produces the mark on the joint because of the force. So that is the main reason for anticonial. Particularly in long-standing cases, only they'll usually have anticonial notch. If it is going to be more than a year or two, then they develop the anticonial notch. But if it's a very short duration, you don't see the anticonial notch in those patients. So it's mainly because of the two different group of muscles acting in the opposite direction.
Got it, sir. So does meniscus follow condylar head during dislocation, sir?
Very difficult to answer that because we can't exactly tell. Meniscus can get dislocated, but at the same time, there is the particularly bilaminar zone. They try to catch the meniscus to a certain extent, but if it is going to be a chronic one for the patient who has got a severe dislocation for many years, then the disc may not be there at all, or the muscle attachment of the posterior bilaminar zone may not be there. So disc is usually gets completely medially displaced. So usually it will be more on the medial side of the joint, and maybe the meniscus may not be there. But it's very difficult to say that whether during dislocation, whether the meniscus accompanies the joint or it is staying away from the joint. So in that,
sir, for chronic dislocation patients, sir, on the dislocated position, if you are going to take a MRI, shall we come to know, sir, whether it's fully displaced along with the head, or it's...
You can, that's what I said. The MRIs can show that, whether it will happen to all the patients, it is not, we cannot confirm it, because it can happen, but at the same time, it is not a must to happen also. It need not happen all the time, but it can happen. The disc can get torn from the posterior attachment, come with the condyle itself. But when it cannot go back. If it comes like that, when the patient reduce the dislocation, it cannot go back. The disc is going to remain in the same place where it has come forward.
Got it, sir. Got it, sir. Sir, what is prolotherapy indications, advantages, and disadvantages, sir?
Prolotherapy is, again, it is just a regenerative injection. They call it regenerative injection because it helps in regeneration of the affected tissues. If there is some problem with the tissue damage due to trauma, not pathology. If there is a tissue damage due to trauma, then you give this prolotherapy inject, then it allows to regenerate from that place. That is, mostly they inject 25% dextrose into the in TM joint they use. But now of late, we have started using autologous blood, particularly in these patients, chronic dislocation patients where they have severe joint pain recurrent. Prolotherapy has been used for many years, but from 1937 was the first time it has been used. But now of late, we have tried a few patients with autologous blood. It works better than that, and it's much faster. The improvement is much faster, and it works much better than they're using the 25% dextrose. It helps in tissue repair in a faster manner, particularly the disc is damaged somewhere on the muscle, which is very close to the joint. If there is some tear or anything, it helps in healing and repair much faster. That is only the advantage of this. But the autologous blood has got a better effect than the dextrose, 25%.
Got it, sir. Sir, factors that decide conservative or surgical management in a patient with complaint of TMJ pain.
TMJ pain, again, as you said, TMJ pain, conservative management. I mean, immediately, that's what I said. Since I used to tell my PGs and my other junior colleagues, if you might be doing a lot of joint surgery, but don't tell about the surgery to the patient. Conservative management is the best for TMJ pain. Try to do as much as possible. Don't tell them about the surgery at all. Because, again, always this, if you see the TMJ pain, the factors, always it will be confusing. One day they'll be all right. Suddenly, 3 months they'll be all right. Again, suddenly one day they'll come and say severe pain and thing. And various other associated problems are also there, not only the local causes, but there is some other local, like stress induced, one of the major factor for TMJ pain. So surgery is not the first option at all. Always try to conservative as much as possible. But if according to if there is an internal dearrangement, again, according to the Wiki stage, you have stage 1 to stage 5. And if it is stage 5, stage 4, if again conservative as well as surgical, you have options are there. But if it is stage 5, then it's only surgery is the only option you have to do it. And Demetrius has, in his new classification, has given a very good reasons and the way to decide about the surgery, what surgery has to be done. So that is again, it's very, you can follow that Demetrius stage, you can know that. Again, he also puts it on the stage 5 only for surgery. Till that time, try to do the conservative management and other managements, only not to think of surgery first.
Got it, sir.
This is that what Demetrius has told.
This is the last classification, sir.
Yeah.
Sir, does the extraction of maxillary third molar alleviate TMJ pain, sir?
I mean, that's the question is slightly, I mean, I don't know whether, what do they mean, whether after extraction the pain becomes more or before extraction the pain is more. That is one thing I'm not able to show. If before extraction, of course, yes, if there is a buccal version of the tooth, too severe buccal version of the tooth, patient might have some pain. When they come with pain, you examine, you see that there is a severe buccal version. Because the coronoid impingement will be there on that, so the patient will try to shift the mandible to a certain extent without their knowledge, so that might produce TMJ pain. So in those patients, you extract the tooth, they have a good relief. They have a good relief, the joint pain most of the time goes away. But after extraction of upper 8 molar, third molar, pain, I have not seen anything pain. But there is one theory saying that to fracture the pterygoid tuberosity for chronic pain, they just try to disjunction the pterygoid maxillary tuberosity and the the pterygoid plates. That there is some literature, and Dr. Varghese Mani also used to do that, and that they used to say that very good relief is there. But I am not sure about it. But upper 8, before, if it's severely buccal-outer tooth, that can produce coronoid impingement. Patient might have to shift, so that because of that, joint pain can occur. But after removing a third molar, joint pain, I have not seen.
Got it. Sir, ideal treatment choice for recurrent dislocations, sir?
Ideal treatment is, again, conservative. You can just try to put them on some splints and try to manage with the bite tracing. But if it's still, it is very, very severe dislocation, surgically, if it is thick, one is eminence, try to augment the eminence. The augmentation, always you have to put a graft, which is more difficult to put a graft in that place. So I normally, what you do is a Daughtry's procedure. I've done few cases of Daughtry's procedure where you try to fracture the zygomatic arch in front of the eminence, bring the arch and the anterior part down so that the eminence become much prominent. So you don't require a graft. So I've done few cases and it has worked very well. But augmenting with the bone graft, somehow I am not very in favor, because maybe I didn't do it properly. I had 1 or 2 cases which didn't work out very well. But augmenting with the Daughtry's procedure, yes, it works very well. Another thing is capsulorrhaphy. You can do a simple capsulorrhaphy or inject a sclerosing solution. Conservatively, you can try all this. Everything fails, then you can go for think of doing a surgical management.
In TMJ internal derangement, the arthrosynthesis was open surgical management, sir. Which you prefer, sir, or which is the treatment of choice, sir?
For internal derangement. Internal derangement, yes, arthrosynthesis. Conservative management, then arthrosynthesis. That's what, again, here also same thing I say, only do an arthrosynthesis itself gives a good relief, at least for 3 to 6 months. Patient have after some time, but they might come back again after 6 months with pain. But again, you can repeat it. But discopexy, doing a discopexy again, until the patient himself comes and tells you that, doctor, please do some surgery for me to correct. I am suffering a lot. I am not able to do anything. Only then you think of doing a discopexy for the patient. But otherwise, conservative management is the best for internal derangement. And arthrosynthesis really works very well, at least for some time. For depends, minimum 3 months to 6 months. They are 100%. They are really getting relief. But maybe they might come back again, because the reason of the pain is various. As I told you, there are so many other factors which are associated with other than the local factors. which unless it's getting relieved, they might come back with pain again. So arthrosynthesis really works very well for the TMJ pain. Voila, you're not audible. You're frozen.
So there are a couple of doubts that they have asked, sir. Can I ask you them, sir?
Yeah, please, please.
They've asked if there is an anchorage loss and management when ankylotic mass removal is done first in pediatric age group. So while doing the ankylotic surgery, if there is an anchorage loss, how do we manage? I think that's the question, sir.
Anchorage for what?
So the question is very unclear. They've written anchorage loss and management when ankylotic mass is removed.
I mean, what is the ankylotic remove it, but what is the anchorage loss? I'm not able. Anchorage loss is only in ortho treatment I have heard, orthodontic treatment. But what is that got to do with ankylosis? I'm not sure. Question is not clear.
Yeah. Then indications of peak in TMJ prosthesis, advantages and disadvantages, sir.
Indications?
Of peak, P-E-E-K.
Peak for indications for?
For
Hello?
TMJ replacements, sir. For
TMJ replacements.
No, I've already told no replacements is unless there is joint destruction is there, osteoarthritis, rheumatoid arthritis, and repeated ankylosis, or patient is able to afford first time and a young adult patient where you want first patient is able to afford, then you can indications. That is the main indication for TM joint replacements.
So I think it's the same question. Balaguhan sir, you can finish with the rest of the questions on PPT, sir.
Yes, please. So ideal surgical approach for temporal joint surgery and key steps of dissection, sir, for any particular.
For temporomandibular surgery, again, depends on what surgery you are going to do. If it is going to be only a discopexy, a high condyle shape, a simple, small, blast-free, a modified blast-free auricular incision is much enough. But if you are going to do an ankylosis, then it's always you need a little wider extension. You can go for an Alcaz-Bramley incision and try to extend it and then do it. But pros and cons of other nowadays for TMJ replacement, you have to along with you use a submandibular incision also. You have to use a submandibular incision to put the condylar fragment into the glenoid fossa to bring it to the glenoid fossa. So it depends on this type of surgery what you are going to do. But normally what we follow is a pre-auricular incision. That's our best thing to follow. Only thing is that modifications you can use. And when you are doing a pre-auricular, first thing you have to take precautions to see that you get the proper plane, the temporal fascia go into the plane so that you don't go and then try to protect the zygomatic-facial and zygomatic-temporal branch of the facial nerve. That is a few things which you have to take care of when you're doing a pre-auricular incision. Other than that, I mean, there's no major things which you have to get the plane, go to the joint, do the joint surgery, then it works very well. Main thing, getting the plane is very important. Go in the proper plane.
Sir, what's the role of temporary anchorage devices in TMDs, sir?
Sorry?
Role of temporary anchorage devices in TMDs.
Anchorage devices, yes, you can use it. Again, as I told you, there are various methods or various types are being used, but it again works in some few patients. It works very well. Few patients they still complain of discomfort and they are not able to compensate. Again, it depends on the selection of the patient and the patient problems.
Guhan sir, are you in?
Yeah.
Balaguhan sir, are you in?
He is in. He is in.
Bala.
Bala?
Um,
Bala? Dr. Madhu, if you have the presentation, you can
the
share.
questions that today not many questions, so I think we should. I'll just check if there's anything else, sir.
Now, if you have the presentation, you can share the screen.
Just a minute.
If there is any issue with Bala. Yeah, Bala is back.
So diagnostic protocol for NPDS and the management, sir.
Diagnostic protocol
can you
again.
able to hear me?
Hello, sir.
We have to hear me.
Yes, Bala, we can hear you.
Hello.
Bala, you are audible.
Hello.
Hello, sir. Can you hear me?
I can hear you, Madhu. Am I audible? Am able to? You are able to hear me?
I can hear you. So I think Bala sir's lost his mic, sir. So the next question was treatment for NPDS, sir, myofascial pain dysfunction syndrome. How do we diagnose and manage, sir?
Diagnosis,
I'll just
main thing you have to see for the pain, discomfort in the head and neck, limitation of the motion of the movement of the joint noises, either can be grating, clicking, snapping, or tenderness on palpation of the muscles of mastication. These are the few things it can be there. If there is a disc displacement, then as I told you, there is definitely MRI will help us if there is going to be a disc displacement. Management, again, mostly NSAIDs, muscle relaxant, antidepressant, and trigger point injection, therapeutic anesthetic block, physiotherapeutic modalities, heat, cryo, counter irritation, vibrators, electrogalvanic stimulation, TENS, active stretch exercise, various things have been tried and works on different patients and differently. But these are the things which you can do for a TMJ pain.
So why is Ringer's lactate preferred for arthrocentesis over the other solutions,
Because
sir?
the osmolarity is the same as the serum. The main thing it is being used mainly because the osmolarity of the serum and the Ringer's lactate is almost similar. So that is the thing, the patient are able to tolerate it well and it does not produce any side effects. So that is the reason why it is being Ringer's lactate is being used for arthrosynthesis. But some of them saline also, but Ringer's lactate is always better than using a saline.
And what is the role of hyaluronidase and dexamethasone and also? Is it advised?
That's what it's a fibrinolytic thing. It produces anti-inflammatory effect also. At the same time, it's got a fibrinolytic effect. So if there is any additions of the joint that it gets relieved and it's slow acting, at least takes for a month, it's slowly acting and then it gets released. So that is the main reason for giving hyaluronidase. It reduces the inflammation of the joint.
Okay, sir. So another favorite question of examiners, what's SMARC procedure?
SMARC procedure is one of the oldest. First ankylosis was done by SMARC procedure. It is one of the oldest technique which is being done. And maybe a few years back, about 10, 15 years back, we had some cases which have been operated third or fourth time bilateral ankylosis. So we have done few SMARC procedures. That is just on the extraoral, put a small angle of the mandible, put a small incision, expose the ramus, strip the masseter and the medial pterygoid, expose the angle, and then try to remove a wedge of bone in between this and almost up to the gap of 2.5 centimeters. It should be tapering up from above downwards. So the wedge should be on the in the inner side of the mandible, and the bottom side of the mandible you have the broader surface. And then mobilize the temporalis and the medial pterygoid and the masseter. Try to suture it in this gap and leave it. So you develop a pseudo joint in that space. So that is the one which is called a SMART procedure. In the next slide, I think that I've just given a picture. You can Bala, can you change to the next slide?
Yes, sir. Yes.
If you see this picture, you will understand about this. You can just see that you try to mobilize the medial pterygoid as well as the masseter and try to join them in the gap what you have created in the wedge of bone. And then that forms a pseudo joint there. So the patient is able to open the mandible, and the callus will be the same. It will not be disturbed. And this is done particularly only in cases where they have repeated surgery 5 or 6 times have been operated. They have a very huge callus where you can't go and operate again. Then you think of a SMART procedure. But now the joint replacements having the thing, I think a SMART will become not very
extinct almost. Yes. So chances of recurrence in TMJ ankylosis surgery.
Recurrence, as I told you previously, when we are doing that muscle interposition, gap arthroplasty, we used to have recurrence in the joint. But after this, doing a dermis fat graft, I found out recurrence is very, very, very minimum. And particularly if you're going to do a reconstruction along with your gap arthroplasty, you will have a very good result. That is what I can say. But they used to have recurrence, particularly young children, because their post physiotherapy will be very, very poor from the expecting cooperation from the child will be very difficult. So they all invariably at least 30-40% of them go for a re-ankylosis. And before, again, when we used to use the costochondral, originally we used to use a longer cartilage head, so that invariably it get fractured, again they go for re-ankylosis. But later we started using a very 1.5 millimeter thickness of graft only used to keep it that rib, and then that works very well.
Okay.
Recurrence is not very common these days. If you do a proper arthroplasty and with the muscle interposition, dermis fat interposition, then recurrence is not that much.
So I think those were the questions that we had for that was already asked, sir.
Okay.
Balaguhan, sir, I think now he can hear us. Hello?
You're not audible, Bala. You're not able to.
Okay, sir. So I think the question-wise, we had only those many questions. So if you can take few online questions for the participants, sir.
Okay.
For proper diagnosis of temporomandibular disorders, clinical examination and various other radiological investigations, which we normally follow, but latest methods of diagnosing TMD, does it have any added value to arrive at proper diagnosis? I don't understand the question. They're trying to ask that we usually use clinical examination history and the radiological investigations,
Yes.
sir. So the recent advances that are used in TMDs, they've said like DC TMD, does it have any added value?
I don't think clinical and radiological, particularly MRIs, can work quite useful. But other than that, I mean, I don't find anything more valuable. Clinical assessment is the best. And confirm it with your MRI.
Okay, sir. So the next question is, a pediatric patient around 12 years is having multiple surgeries for bilateral TMJ, but re-ankylosis keeps happening. So can we go for TMJ processes? If he's 12 years old and he's got recurrence of ankylosis, at what age can we do the TMJ processes? Can we do?
TMJ processes, according to the thing, they said only after the growth period is over. Till the growth period, you can't do the TMJ prosthesis. So you have to wait for the growth period to start. But for repeated thing, you have, I don't know. As I told you, before it used to happen, but nowadays, if you do a proper surgery and interposition is good, I mean, and try to follow the protocols, what is required, I mean, you don't see much of pre-ankylosis.
Okay, so if a child has a fibrous unilateral ankylosis due to trauma, and we encourage mouth opening exercises for a long term, sir, good physiotherapy is being given, then can we avoid surgery? Can we avoid bony ankylosis? That's another question, sir.
If the joint is still moving, then they will not go for an ankylo. But if the joint is not moving at all, the fibrous ankylosis will go for an ankylosis. Sometime or other, it's going to go for a bony ankylosis. So better if you feel that it's not improving, then try to go create a high condylar shave and try to interpose little dermis fat graft. It works very well.
Okay, sir. There's another question. Is there any age limit for SMARC procedure, which you already said is going to become an extinct procedure, but someone's asked, sir, is there any age limit for SMARC procedure?
There's no age limit, not on young patients, but if that's what repeated ankylosis means, actually 5 or 6 times you would have got ankylosing surgery done. Still he has gone for a re-ankylosis. The callus is so huge on the medial side, it will be almost very close to the internal maxillary artery. So then internal carotid canal, then you feel that you're going to be in danger again removing the callus, then you can go for an SMARC procedure. Upper age limit, nothing is there, but for lower age, yes, on a well-grown adult only you can do
it. Again, asked for the DCTMD, which is the diagnostic criteria for temporomandibular disorders. I think that question is already asked. Who has been asking it to me repeatedly. Diagnostic criteria for temporomandibular disorders, though it keeps coming in your literature and articles, you still go by your clinical evaluation. I think sir has already answered that question. The other question is, for reconstruction, what would we prefer, sir? Costochondral graft or sternocleido graft?
Costochondral graft. Sternocleido is, I mean, they say it is almost good, but the surgery is much more complicated and more difficult. It's, I have not done any sternoclavicular joint. I have seen one done by Dr. B. Srinivasan many years back, but I have not done any sternoclavicular joint. But costochondral is much better surgery, I think.
And then there's a last question. Can you share an article for SMARC procedure? I think PGs, you need to do that bit of work to search your article. If we get, we will share it in one of your links. I think you've answered all the questions, sir.
Yeah. Okay.
Everything. Jimson, sir, is there anything on YouTube or Facebook questions? Because sir has taken all the questions on Zoom.
No, there are no questions in Facebook. We are not live on YouTube because there's some technical issue. So
okay,
we are live on Facebook. There are no questions in Facebook. So you can go to the next session.
Okay. Actually, temporomandibular joint is, though the joint is very small, it's always a huge question mark subject, sir. You beautifully explained it to us. Thanks a lot for your time. And thank you for taking all the questions, sir.
Thank you, organizing like Jimson, Balaguhan, and Dr. Madhu for giving me an opportunity to talk in front of, in this forum. I thank you very much. I'll be very happy to take some more questions.
If we get, we will keep you informed, sir.
Oh, yes. Thank you very much.
Thank you, sir. So the next session today will be on cysts and benign tumors. Your mentor for the day will be George Paul, sir, whom I've already introduced, and your moderator will continue to be Dr. Balaguhan, sir. Balaguhan, sir, are you available?
Yeah.
Yes, sir. Can you share your screen also, sir?
Yes, I'll share
please.
the screen.
Thank you, sir. George Paul, sir, is muted.
Sir, muted, and my screen it's not coming. Okay, so.
Try to share your screen, sir.
Coming by your screen, I think.
No, sir. I have stopped my screen sharing.
Okay. So it's not resumed. Okay.
Can I share my screen? Is that possible?
Yes, sir.
Yes, sir. That is
Definitely.
possible, sir.
Yeah, if that's possible. Is it possible? Is it?
Yes, sir.
Is it
Yes,
an
sir.
issue? I can. Yeah.
Yes, sir.
Okay. Let me see if I can do this. I am technologically handicapped, so let me just check.
Uh,
No, Bala, you have to stop sharing. Then only sir can start.
yes, sir. I did that, sir, but it's not working. I'll do that, sir.
Okay, I have stopped it from my side. So, sir,
Yes.
So
sir,
I have.
you
So
can,
I'm
sir.
just
Yes.
I'm trying to figure out how it's done. I'm not very sure.
There's a green button on the
Share screen.
share screen button, sir.
Oh shit! What's happening? All the way back, is it?
Sir, can I try once more, sir?
Yeah, I have something here. Yeah, please try it. Go on. Yeah.
It's not coming, sir. It's not coming. Jimson, sir, should.
Okay.
No.
Hello, doctor.
It's already shared.
Okay.
The presentation.
I'm just putting the shares.
Yes. I'll send it to the mail.
Is
Yes,
this the shared screen?
Yes, sir. Yes,
Okay.
sir.
Is it?
Go to the presentation mode, sir.
I'm sorry.
Sir,
Presentation.
here, the next to 72% one symbol is there, sir. You can click that one, sir.
I'm sorry. Next to.
The lower 72% one thing is there, sir. Next to that one symbol is there, sir.
The bottom,
Right
Right
sir. The
hand
bottom.
side lower, bottom, sir.
Yeah. Next to that, yes, the slide.
Next,
So,
next,
right.
yes,
Right.
Yes.
You
No,
got
sir.
that?
Fourth one, sir. Fourth one.
This one, sir.
How do I go down on this? Okay. Okay, I just go down to. Can you see the screen now?
Yes, sir. Yes, sir.
Okay. So I'll just go ahead with this. So I have to ask the question and I have to answer the question, is it?
I'll ask the question, sir. Probably you may
Oh,
be hearing it.
Yeah. Yeah.
But yes, sir.
Yeah.
Sir, you have to change the slides.
Okay. Yeah, I'll do that. Yeah. So yeah, I see Mutshega's picture here, which doesn't matter. He is a better looking guy than I am.
That was a very old picture, George. It's not
No,
new.
but why is my picture not coming on this?
No, we are able to see you. We are able to see
Oh,
you.
you're able to see me. Okay, fine. That's fine.
I have come out of the video mode, so only my picture will be there. You won't be able to see me. Only the picture.
Okay, so you can see me making the presentation.
Yeah, I can see
Right.
you.
Okay, I can't see it. I don't know why. We have to put something here. It doesn't matter. These questions were not drafted by me. They're obviously questions which came from postgraduates. I understand that the audience is largely postgraduates. Am I right? It should be mostly postgraduates.
Yes, sir. It's postgrad.
Yeah. So Govind, you can go ahead and ask me the question.
Yes, sir. I think you have to change the slide, sir. You have to change the slide, sir.
No, the first question is okay. Yeah, right. It's an ideal simple classification for non-odontogenic cysts, right? See, I think one of the important things that postgraduates must realize is that our examination system is not very objective in the sense that different examiners have different views about various things, and there are a plethora of classifications that are available to choose from generally, and people choose one or the other of these.
Sir, we cannot see the slide, sir.
You can't see the slide?
No, it's in the first slide actually.
Okay, then I don't know what's the matter.
No, you
No,
can
allow
change the
Bala
slide.
to share the slide, George.
Yeah, I'm stopping sharing. Okay, right. Bala, can you see it?
Yes, sir. Yes, sir. Yes, sir. We'll share the screen, sir.
Yeah.
So you want me to share the screen if you're okay? Will it be easier
Yes,
for
doctor.
you?
Yes, doctor.
Yeah,
Please.
that is better. That is better.
Better.
Yeah, you can, please.
Is it clear for everyone, sir?
Yeah, fantastic. Yeah, you can go to the presentation mode.
Yes, I'll be there, sir, in 2 minutes.
Oh, yeah.
The presentation mode, doctor.
Yes, sir, just a minute. I'm getting it on. Is it okay, sir, for everyone now?
No, it's not in presentation mode, I think. Is it?
Yes, sir.
No, you have to go enable editing, then you have to come for a presentation mode.
You have to press on enable editing on top. Is that right? Is that okay?
Yes.
Right, okay.
You're okay now, sir?
Okay.
Oh, it's okay.
So an ideal classification. So what I was trying to say is that there is no such thing as an ideal classification because classifications keep changing. You know, if you look at the first classification that was made was by Aristotle, perhaps, when he said animals and plants. You know, so we try to put similar looking clinical in medical science. We try to put similar looking medical subjects into certain clusters, and it may be based on your clinical evaluation, it may be based on your radiological evaluation, it may be based on pathology. So I'm not going to go through any of these classifications because these are all freely available at your online, and you have a plethora of them to select from. So just to give you an example, I'm not going to go through all these things, but one of the questions that was asked was, what is a good classification for non-odontogenic cysts? Now this looks like a good classification because it can be developmental, which means they are remnants of the developmental process which are stuck in the bones or in the soft tissues which proliferate for various reasons. Or it may be inflammatory, that may be secondarily. Now, if you look at this carefully, I mean, some of these like median palatine cyst and median mandibular cyst are very rare. I've never seen both of them really, to be honest. And of course, it's subdivided into intraosseous and extraosseous in developmental, among the developmental non-odontogenic cysts, and inflammatory. Now, if you look at inflammatory, really, some of them are not really inflammatory. Like, for example, the traumatic bone cyst and aneurysmal bone cyst are not actually inflammatory bone cysts. They are not even cysts really in the real sense, because a cyst is defined as a pathological cavity lined by epithelium, and both these are not lined by epithelium. So if you ask whether this is a perfect classification, it isn't. So you will find several of them, as I'm going to show you. Can I go to the next slide? So you have, for example, you have the odontogenic tumors being classified. Now, this is a 2017, the latest classification. Later, I will be telling you about some of the changes that have been made in the 2017 classification. But you find that this classification more or less retains the previous classification, but several changes have been made. Some more malignant type of odontogenic tumors have been brought in. Some like KCOT, which was a keratocystic odontogenic tumor, which was classified as a tumor for about 10 years, has been removed. So you find changes that often takes place. So this uncertainty about classification is one of the reasons why you have so many classifications coming. So I would urge all postgraduates to actually mine the internet and the online things to look at various classification, choose your easiest one rather than me telling you this is the easiest one, because another examiner may not accept it. Can go to the next one. Next, you can move. Yeah, you can move on to the next one. Say another class, no, previous one. Previous, yeah. Previous, please, yeah. So this one is, for example, a radiological classification, not of cysts, but of cystic lesions. They may be tumors, they may be cysts. So this is one way of looking at it. So I put all these up just to give you an idea that classifications are not written in stone. They can be changed from time to time, and world bodies, including the Indian classification, international classification for diseases, the WHO's classifications do also change from once every several years. So you need to have a very clear view of what the latest classifications on these are. So that is an important thing that you need to observe in your postgraduate program. So there's no ideal classification. There's always a classification that you can choose from. Just to give you a picture of an odontogenic tumor, I mean, it just so happened these were all introduced in the last minute. Next slide, yeah. And I was not sure whether when we talked about cysts and tumors, whether fibrosous lesions are also part of them. It was a little vague in terms of the topic. And this particular classification, which came in 2006, 2007, has some of the lesions which we will discuss among the cysts and tumors as well. So there is a lot of mix and overlap of all these lesions that you find in classifications. So you need to sit down and probably try to pick out a classification for different things based on the questions you're likely to get. And never argue with your examiner, because your examiner always comes with a prefix idea about a classification. So you always accept it unless you have a citation or you're able to quote from where you got this classification. Yeah, next slide. That's a question about classifications. What is an ideal classification?
So
this is a, yeah, sorry. Go ahead. Go ahead.
Ruhan sir, you need to ask the questions.
Yeah. Go ahead, go ahead. You can ask a
yeah,
question.
difference between ameloblastec carcinoma and malignant ameloblastoma, sir.
I think before we actually come to the ameloblastec carcinoma and malignant ameloblastoma, we should understand what an ameloblastoma is. An ameloblastoma, as you know, is a tumor from the tooth-forming tissues, and these ameloblastomas are locally aggressive and rarely metastasize. And the treatment is fairly standard. You do an aggressive resection, or these days many people do curettage for these lesions, and especially the unicystic type A type of ameloblastomas and things like that. But when you actually look at these two things, the ameloblastic carcinoma and malignant ameloblastomas, these are very rare. So I don't know where this question really came up from, but I just want to mention that if you know that it is an ameloblastic carcinoma or malignant ameloblastoma, you don't treat them like the conventional ameloblastoma. You treat them a little more aggressively. A curettage certainly wouldn't be enough. You definitely need to do a resection. The reason is, particularly ameloblastic carcinoma is much more aggressive. It has a tendency to metastasize, which normally ameloblastomas don't have. Both these, even malignant ameloblastomas do metastasize. But the ameloblastic carcinoma is a much more aggressive lesion. It produces more neurological signs. It produces more amount of destruction of bone. The cortication that you normally see with ameloblastoma is not there, whereas the malignant ameloblastoma is more or less like the regular ameloblastoma. So they can be treated a little more conservatively. These are all relative. So I think you need to be very careful when you come across an ameloblastic carcinoma, because you almost treat it like a carcinoma, including radiation sometimes is required. Yeah,
we have to go ahead with neck dissection, sir, for ameloblastic carcinoma.
If an ameloblastic carcinoma has a neck node, because it does metastasize to bones and distant organs, and there is a possibility that it can metastasize to the nodes in the neck. If it does, I think you need to do it the same way that you would manage a carcinoma, in the terms of looking at either you look for sentinel node or do a. But I have actually presented I have published a series of 6 ameloblastic carcinomas. We didn't do prophylactic neck for all those cases. But if you do have a suspicion that there might be a node, I think it might be good to do a prophylactic neck dissection or a therapeutic neck dissection if it is required.
Got it, sir. So the odontogenic keratocyst, whether it's a tumor or cyst, it's a very long debate, sir, from WHO classification onwards. And pathogenesis, management of aggressive odontogenic keratocyst, and recurrence also, sir.
This is exactly what I was saying before when we saw the classification. See, until 2006, it was called a cyst. From 2006 to 2017, for about 11 years, it became a tumor. In 2017, it again became a cyst. The reason is that it's neither fish nor fowl. You know, the OKC behaves like a cyst sometimes and it behaves like a tumor sometimes because of its aggressiveness. So many people have a tendency to think of it as a tumor and treat it as a tumor. And the expansion of a keratocyst, for example, is not like the expansion of a regular cyst, which is by hydrostatic pressure. The fluid that forms inside the cyst exerts pressure on the walls and it expands. On the other hand, the OKC expands a little by pressure, but largely by mitotic activity. So it has larger amount of mitotic activities. A lot of theories on how they actually expand. They all have daughter cells, daughter cysts, and that's the reason why you have a very large percentage of them recurring. I've read Paul Stollinger's very seminal article on odontogenic keratosis, where he believes that the odontogenic keratosis may not actually completely originate from the dental lamina, remnants of the dental lamina. It may actually originate from the basal cells of the oral mucous membrane as well. So if that is what is happening, then the way you need to deal with the keratocystic odontogenic tumor, or OKC, whatever you want to call it, is by removing a wedge of soft tissue along with it, so that you remove the causative factor as well. And since they have daughter cells, it's always good to treat them aggressively. You curate it, you use chemical cautery if required, and then remove it. So you don't actually treat it like you normally would a dentigerous cyst or a radicular cyst, where you just enucleate the cyst. You have to be much more aggressive. And the recurrence rate they show here, there's a problem with the recurrence rate is because the pathologists are the ones who have always talked about the recurrence rates. There's not much of study really on the recurrence rates. I think the recurrent rates are much, much lower than what is believed. I've seen some articles where they say there's almost a 50% recurrence rate. So I don't think that would happen. If you remove all the lining, you removed all the contents, the possibility of daughter cells, did a chemical cautery and curettage, and you left it open, which is an idea which is again propounded by Paul Stollinger, so that no pressure builds up inside and it heals. It heals beautifully. In my hands, I found it to be extremely good. Yeah. Just to show you a picture. Actually, this was an ameloblastoma, but keratocyst behaves quite like this. You see in one picture, you see the cyst with the tooth inside there. It's not a dentigerous cyst, it's just the tooth is pushed to one side. You see the second picture is a curettage that we have done. We just done a curettage. This is how I do it for ameloblastomas as well. Treat it with carnoid solution, and 2 years later, you see the bone has formed perfectly. So, this unicystic type A ameloblastoma and OKC behave almost similarly. The one is one is a cyst and one is a tumor. Yeah.
Next slide. So the principles and involved in management of cyst.
Yeah, the principles are fairly clear. I think you just, as I said earlier, you enucleate in the case of inflammatory cysts like dentigerous cysts and radical cysts. But in the case of OKC, you need to do a little more than that. You may have to do a peripheral ostectomy or a very thorough curettage and chemical cautery as well. So it depends on which cyst you're talking about. So the principles are like that. This is a regular cyst. It's not an OKC. You can see that the cyst is just lifted out. You can see the bare mucosa inside. I sometimes leave my cysts open. I pack it and leave it open because I've had some bad experience of bleeding from the cyst post-operatively. When you close it, it forms into a hematoma. So I usually pack it and then I remove the pack after 24 hours. This is for an enucleation, not for keratosis. I leave them open until they heal and form back into good bone. Yeah.
So the dentigerous cyst management, is that the enucleation versus marsupialization, sir?
Yeah, I mean, a lot of people, I remember when I was a student and when I was a very young surgeon, I remember marsupialization was very strongly advocated, especially if the cyst is likely to, I mean, enucleation of a cyst is likely to endanger the a tooth or a nerve or is very close to the maxillary antrum. Then you marsupialize it, which means you connect the cyst lining to the oral mucous membrane either with an obturator or suturing. And then the bone forms because bone mitigates against pressure and it starts forming inside and slowly forms up and moves away from the structure you are trying to avoid. And then you can do an enucleation. That is called the Waldron's procedure. But I don't do that. These days, I just enucleate it and close it. As far as a regular cyst is concerned, OKC, as I said, we are much more aggressive with it.
So the same way, sir, aneurysmal bone cyst, sir, for enucleation or
Yeah. The aneurysmal bone cyst and the traumatic bone cysts are extremely rare. I have seen just 3 or 4 of them in my career. And the aneurysmal bone cyst, the pathology is very vague. People don't know exactly why it forms. It usually, it looks like it has a honeycomb appearance on your X-ray. And if you took an X-ray, if you took a biopsy, you would see some amount of giant cells actually in it. And you'll also see some amount of trabeculate bone and spongy material. That usually gives you an idea about aneurysmal bone cysts. They bleed a lot, aneurysmal bone cysts. So usually when you open to treat it, you also go ahead and remove it. That's the best thing to do. But aneurysmal bone cysts have a tendency to recur very often. So you need to thoroughly, can I just go to the answer? This thing?
Yes.
There's an answer for it. Yeah. So do a complete curettage and I leave the cortex open. We do a lateral cortication and leave it open and it heals. The very few number of cases I've done, all of them healed well, but they do report a large amount of recurrence for aneurysmal bone cyst. But it's not very dangerous. It can become quite big. It can expand quite large. Pathology is not very clear. It's believed that aneurysmal bone cysts are caused because of the capillary pressure in the fibrous tissue that has invaded into the bony space in which it's formed. So that starts expanding. That's why you have both a fibrous type and a vascular type of aneurysmal bone cyst. That's going a little far.
Whenever we try to open the aneurysmal bone cyst, sir, for incisional biopsy, once the bone expansion, we just want to do an incisional biopsy. Nothing is there, sir. Only the roots just standing or it's floating. So only
I think, Guhan, that is more with bone cysts. You find empty cysts,
yes.
Completely empty cysts.
Yes.
And the treatment is almost quite similar. And aneurysmal bone cysts are quite like empty cysts, except that they have fibrous tissue and some blood vessels. So it tends to bleed a lot, aneurysmal bone cysts. I've seen a couple of traumatic bone cysts. They're just empty. I think a clot forms, a hematoma forms, and it resorbs and goes away, and you have nothing else left inside. That's just an empty cyst. Both these are not real cysts actually because they're not lined by epithelium.
Yeah. Got it. Dr. Madhu, next slide, please. Dr. Madhu.
Next slide. Not moving?
1 second.
Madhu's not there?
Dr. Madhu?
She's probably taking a break for dinner.
Doctor, next slide. Doctor.
I think her screen is also frozen. I think there are a couple of questions in the chat box in the meantime. I think if you can.
Yeah.
Bala.
Shall I tell the question? Can I tell the question? What is the question? Next question.
Yeah, that's fine.
Yes.
What are the management strategies for benign tumors?
Oh, well, benign tumor. Okay, from cysts we have moved to tumors. As I said, OKC is almost like a tumor, so we explained something about that. But I think tumors, amyloblastoma would be the most common tumor that you see, and recent advanced management. Okay, can I just go up one more slide? Next slide. Yeah. The management of tumors is next one. Yeah. More and more, I think people are becoming conservative even with ameloblastoma. They tend to enucleate. I never used to do that. I always did a resection. But these days, I am enucleating a lot of them. You do a thorough enucleation, just like you do for that picture that I showed you first as an OKC was actually a tumor. You can do a thorough enucleation and a curettage and treat it with chemical cautery. It sometimes works. I mean, things like ameloblastomas. And of course, the tumors are divided into ectodermal, mesenchymal, and mixed origin, depending upon whether it's a cementoblastoma for mixed origin, ameloblastoma if it's an ectodermal origin, and many of the mixed tumors that you see. Odontogenic myxoma is a mesenchymal origin tumor. But all of them are treated almost the same way. Enucleation is a good way of getting rid of the tumor, and you do an aggressive treatment of the remnants after you remove the tumor. But previously, and I think a lot of people still do that, is wide resection. That is, you give about a sub-centimeter margin and remove the tumor. Usually the cortical bone is left behind. Limited resection, like rim resection, is a type of wide resection that you can do, which is a favorite procedure for ameloblastomas, which I do because form is left behind and you can always build up on the rest with bone grafts or thing. And then segmental resections in very, very aggressive lesions where you don't have any cortex and it's pretty large and you have to resect it and reconstruct it. Reconstruction, of course, is what Guhan does. He does a microvascular reconstruction would be the best form of reconstruction. But if they're very small, less than 5 centimeters, you can actually use corticocancellous bone graft in a trough and try to reconstruct them. But a few other reconstructive techniques have come up. Yeah.
Sir, is there any clinical sign to identify soft tissue involvement of ameloblastoma?
Yeah, I think the X-ray is the best way to do it, if you ask me. The X-ray shows perforations in the bone. You can assume that soft tissue involvement is concerned. That depends on whether you call the periosteum as soft tissue, because periosteum is a very good barrier for all these tumors. It doesn't go beyond the periosteum. One area that I have found to be particularly tricky with ameloblastomas is the coronoid process is involved. The ameloblastoma tends to latch on to the temporalis muscle. And very often I've seen recurrences happening at the end of the temporalis muscle that you left behind sometimes. So I think CT scans and X-rays are probably the best way. And intraoperatively, you can see soft tissue involvement. When you see them, I suppose you need to excise the soft tissue that is involved. That's what you should need to do.
Got it. Sir, how can we preserve the inferior alveolar?
If you're using carnoid solution, carnoid solution is a pretty caustic substance. They don't use chloroform these days, but even if you did use chloroform, I think it's pretty caustic, and if you leave it there, particularly against soft tissue, it tends to destroy soft tissue. You can see it as a dark a patch that comes up against soft tissue. It's very good for bone. I don't think it does any harm to bone, but soft tissues are vulnerable to the use of carnoid solution. And what I do is, if I'm able to dissect the nerve out and clean it up completely, and I'm happy with it, because you must realize that some odontogenic tumors actually have neural spread as well. So what I do is I wrap it in gauze. I use Vaseline, but I think it says here a wet gauze with normal saline. I use Vaseline on top of the nerve. That seems to help a lot. But even in those cases where the carnoid solution has touched the nerve, I find that the neurosensory deficit is not for a long time. It usually comes back within 3 to 6 months. So I wouldn't be too much worried about that. I think removing the tumor is a more important thing. But of course, you must try to protect it wherever you can. Dissect it out, hold it away, retract it, move it aside, wrap it in gauze. All those things are techniques that you can use to prevent the inferior alveolar nerve from being involved.
So the syndromes associated with the odontogenic keratosis, and can OKC occurs in the cases of Gardner's syndrome?
Okay, I don't know why this question was asked, because I've never heard of Gardner syndrome having
Odontogenic keratosis.
OKC. I think Gorlin-Gortz, Noonans, Ehlers-Danlos, a lot of others have it. I just put up a picture here of a polyostotic, I'm sorry, it's fibrous display. Multiple keratosis. I can see four of them really. Four separate cysts in the jaw, and there was the one in the maxilla which you can't really see very clearly here. So these are usually syndromic, and they're syndromic because the remnants of the dental lamina or the basal cell, as Paul Stollinger says, can form into odontogenic keratosis. And why it forms into keratosis is because of your genetic. And now they've identified, I think, I don't know much about the genetics of it, but they've identified the genetic loci which predispose a person to form multiple odontogenic keratosis, and they're usually accompanied by other features like, can I see the next one? I think I have bifid drip syndrome. If you have not seen a bifid drip syndrome, you can see the bifid up there. The second, the third, there's a bifid there. On the other side, there is a bifid. You can see the bifid drip. This was the case I did about 6 months ago. Bifid drip syndrome is quite common. You have other features like hypertelorism, hypertelorbitism, and I can see that. Yeah, the next slide. I think it tells you several of the other things. Multitude of epidermoid cysts. These are all Gardner's. Oh, that is Gardner's. Here too you have skin lesions in Gorlin-Gott's. Gardner's, of course, doesn't have any of these things, so I think we should just ignore Gardner's. You do see it in Ehlers-Danlos, Gorlin-Gott's, Ehlers, Noonan's, and things like that. Gorlin-Gott's specifically, we see a lot of Gorlin-Gott syndromes which have multiple. They are treated in the same way, but they have a higher tendency to return, because you must remember that you can have de novo lesions because the genetic factor remains.
Got it, sir. So the treatment options for
giant cells. I didn't know whether giant cells were part of this topic really, but I added, I think, giant cells to this. Yeah. See the next slide?
Let
me see them. Yeah. Giant cell lesions are a large spectrum of diseases. And some of them are cysts, some of them are tumors, and some of them are just giant cell lesions. We used to have this thing called giant cell granulomas or giant cell tumors, which reparative granulomas actually. So the name itself suggests that they repair by themselves. I personally had experience of taking biopsies for one or two of these cases where they just started healing, just the mere act of taking a biopsy. So curettage, they say, is an extremely good way of treating them, but they also report a very large number of recurrences. Now, recurrences usually happen. Yeah, I think that's it. Yeah.
Next question for.
The recurrences are usually because of for whatever reasons the recurrences are there, and surgery, non-surgical treatments involve injection of steroids into the lesions, injection of calcitonin subcutaneously, injection of alpha interferon, all these, and even for that matter, bisphosphonates can be used in these lesions. But I have never used any of those medical treatment methods, except, of course, injecting steroids and intralesional steroids. But I found the best results with actual curettage, and they have repaired quite well, although we have had some recurrences, and they can grow to very big sizes. I think that's it. I don't think I covered everything or most things, but we covered from here and there. It's a very big topic, and it's an important topic for maxillofacial surgeons, particularly students who are likely to be asked questions on this. I can take questions if there are any questions.
The often asked questions, Balaguhan, sir.
A few questions are there, sir, in the chat. The mechanism of intralesional injection of steroid into the central giant cell lesions, how do they shrink?
How do they?
Shrink the tumor.
Yeah, let me just think about that. Steroids act by, it's a fairly understood technique. I'm not very sure. I know that calcitonin acts as on the assumption that they are like Brown's tumors. So it acts against hyperparathyroidism. Steroids act. Does anybody know that? Muthushega? Do you know what's the mechanism of action of steroids?
Fibrosis kind of thing, anything?
I'm sorry?
Fibrosis kind of.
No. There is a very particular reason why steroids were used. Whether it's effective or not, the rationale for using is something else. I'm sure you can look it up in the internet. There is a rationale. It's a very interesting rationale. It's for using steroids. You actually use 50% steroids and 50% local anesthetic and inject it, I think 2 ml per every 1 gram of tissue. That's the approximate ratio in which you use it. The rationale, I forget. If there is a rationale for using, you can always look it up online.
And the other question is the potential recurrence for syndromic cysts.
Yeah, syndromic cysts, the potential recurrence is much more, because as I said, the syndromic aspect of it makes the jaw very vulnerable for repeated formation of odontogenic keratosis, much more than single keratosis. Yes.
And how you are going?
Are you talking about syndromic giant cell lesions or syndromic OKCs?
OKCs.
Okay. Syndromic giant cell lesions, not giant cell lesions, fibrous dysplasia was something that I didn't actually discuss. Albright syndrome and things like that. That's OKC syndrome. Gorlin-Gott's has a tendency for recurrences even after you have treated them. Yes. And so you need to keep them under surveillance for a long time.
Yes. Sir. How you are going to apply the Carnage solutions into the?
Carnage solution. I don't know if this is a right way of applying it, because I was never taught how to apply Carnage solution. I just learned to use it myself. So I take Carnage solution, which is of course made by glacial acetic acid, ferric chloride, chloroform, alcohol, etc. There's an oral pathologist who makes it for me. So I apply it for about 2 minutes in different places. I try to protect the inferior alveolar nerve and the soft tissues and use it on bone. Usually the places where there are remnants of soft tissue or daughter cells, you see black spots, and those are scraped away as well. And then we flush it out and
the other question is how much time you can keep the Carnage solution, sir? Once it's prepared, now your surgery got postponed for next couple of days. So how much time you can keep the Carnage solution safe, sir? Otherwise we have to prepare.
Oh no, Carnage solution is only for 24 hours, within 24 hours. It has to be freshly made Carnage solution. Yeah. In fact, I've got some Carnage solution in my fridge. I have a case tomorrow. So it was brought in today because it was in the morning, fixed for morning. I've kept it in the fridge. But
and the regular Carnage solution, whatever we use, and the modified Carnage solution, sir, without chloroform.
Yeah, without chloroform, yeah. Chloroform is expected to be carcinogenic. I think we still use Carnage solution, but in the West, they have stopped using Carnage solution, yeah. They use only glacial acetic acid, ferric chloride, alcohol, and chloroform is removed from the alcohol, of course.
Yes, sir. And the penetration depth of Carnage solution, sir, on hard tissue?
I'm not very sure about it. I think it's about 0.2 millimeters, isn't it? 2 millimeters, yes, sorry. 2 millimeters.
Yes, sir.
2 millimeters is supposed to be the thing. But 2 millimeters is not theoretically acceptable. It has to go at least 5 millimeters or more for completely eliminating. But 2 millimeters is 0.2 centimeters.
The cancerous bone, whatever it's present also, that also make a...
Yeah.
If it is a hard bone, it will be going for up to only the 3 millimeter or something, sir. If it is
I don't think in cortical bone it even goes that deep. In cancellous bone, it goes to about 0.2, 0.3 millimeters. Yeah.
So how important to use a Carnage solution in OKC? Is it mandatory to use?
I swear by it. I use it. But there are many people who don't know. They have these gels, which can be. They use cryosurgical probes into those gels, which is supposed to go to all the parts of the cyst, and then it's supposed to destroy whatever soft tissue is there. I have no access to that. So Karnoy solution has been mainstay for several decades, and I found it to be very useful, not only for OKCs, but also for aggressively treated odontogenic tumors with high recurrence rates like unicystic ameloblastomas, etc. I use Karnoy solution. I think it's magical, honestly.
The last question, sir. The iodoform versus bismuth iodoform paraffin paste. Which do you prefer, or which is the ideal one?
Okay, my preference is bismuth iodoform pack, the BIP pack, because it can be kept for about 10 days. I believe paraffin wax, whiteheads varnish, all of those can be kept for a long period of time. But bismuth iodoform is readily available, at least in Salem. We get it. I'm sure it's available everywhere, and it's my mainstay. Yes, it's absolutely very good. You can keep it for up to 10 days, they say, but I don't keep it for 10 days. But 2 or 3 days, nothing happens to it. No smell, nothing. It's a mummifying agent also, so it's good.
Thank you, sir. Thank you very much, sir. It's a very nice presentation.
So there was one more question on dredging method. Have you asked that part?
Oh, yeah, that's interesting. Actually, do I have time to talk about that? I mean, for
yes, sir. Yes, sir. Dredging method used for treatment of odontogenic cyst.
I think dredging is an absolutely great future, because we talk about doing these resections, especially for young children, doing these major resections for ameloblastoma, and then reconstructing them with there's a donor site morbidity, and then the implants don't sit very well on them. Dredging was actually is a guy called Hazim. He's not Faisal Rahman. I thought it was Faisal Rahman. It was some guy called Anwar H. Anwar. In Bangladesh is the guy who actually started this dredging.
Okay, sir.
Dredging works on the principle of just removing all the cysts that you can see and encounter, and then packing it and giving it an obturator or whatever it is. And then you review it after 6 months, and you see that some amount of bone has formed, but you have not eliminated the ameloblastoma. Ameloblastoma is still there in patches. So once you have the bone, you have at least some kind of a strut. It's like doing a peripheral ostectomy. You have a bit of particle bone. Then you again remove whatever is there. You may have to do 3, 4, 5 dredging procedures, but you avoid having to do a segmental resections, which can be defacing, and the deformity is significant.
So these multiple procedures can be done in what gaps? So like from the first to the...
1 year and things like that.
Okay.
Or as and when they see the lesion. When you take the X-ray, you can see there's good bone formed and there's a lesion over it. And you remove that lesion. And the final thing is actually like doing a peripheral ostectomy.
Okay, sir.
So, especially these are used in extremely large ameloblastomas. It's a very nice article. Try to get that article online.
Sure,
Bangladesh, I think they did about 500, 600 cases. They've had extremely good results. Very few cases had to go for segmental resection. So I think as an organ saving procedure, it's an extremely good surgery.
Sir, and what's the penetration depth of Karnoy solution in soft tissues and hard tissues?
Oh, hard tissue, as I said, is about 2-3 millimeters. Soft tissue, I'm not really sure. It may be long. I tried to not put it on soft tissue. So I'm sure it must be more than that, isn't it?
Yes, sir. Sir, and then there's another question. When we take these specimens, should the biopsy container preferably be glass or plastic, and why? Does it have to have a preference?
Oh, I actually forget. I put it into glass, but I've heard that plastic is better, and there is a reason for it. I'm not really sure why it is. And it should be, what I can tell you is it should be wide mouthed and all those things. And the amount of formalin that you put into it, it has to be so many times more than these. Glass and plastic, I'm not sure. Mutshekar or Guhan, do you have any idea why?
Oh, same thing. I mean, usually before you used to have glass only, but nowadays in the OT they give a ready-made formalin container. Plastic only.
Plastic has some advantage. I'm not sure what it is. It has some advantage. Yeah.
And apparently, sir was muted when we were asking about the role of steroids. I think sir's back.
Yeah. Do you know, Mutshekar, why they use steroids for
giant cell granulomas?
Giant cell granulomas?
More as an anti-inflammatory only. That's what I mean. I try to refer.
No, Mutshekar. There's some other reason. It just slipped my mind. I know what it is, but there is some other logic in using it. I'm not very sure, but I'm sure you can look it up.
I'll try to refer and see.
Yeah, there's some other logic to using that.
And the
I'm not very
carnage
sure.
solution, normally what I do is I make it in small bits. So I have a count
pellets.
of small.
Yeah, I do the same thing.
Suppose I'll have a 20 things, tell the sister to count it, soak them in the carnage, pack it in every corner where I can pack. So I have a count. And when we remove it, we check whether this 20 has come back.
Absolutely.
So that
absolutely.
works very well. That's what I normally have been practicing for almost many years.
Very good. I do that as well. I say 1, 2, 3, 4, 5, 6, and then I count it and put it back again, because you accidentally leave behind the carnage solution, it can actually do a lot of damage.
Yeah, that's what. Better to see that, make sure that you have removed everything.
And also,
and for the inferior alveolar nerve, normally what we do is we, as you said, we pack, coat it with Vaseline. Suppose we see the nerve.
I use Vaseline.
And then
I use
pack
Vaseline. Yeah.
So can you use carnage solution in pediatric patients, sir, for amyloblastoma?
Yeah. I use it. Well, why not? Why not in pediatric patients?
The timing has to be reduced because
no, but they've asked for amyloblastoma. Is carnage of any use for amyloblastoma, sir?
I use it. I use it for unicystic amyloblastomas. Yes, I do.
Originally, carnage was designed for amyloblastoma only. If you take the literature, you see the carnage was first started using only in amyloblastoma. Then only they shifted it to OKC.
What was the mechanism, sir? Because for OKC, we say it's the presence of the daughter cysts and cells, and to get eradicated, we use the carnage to fix it. Amyloblastoma has similar cells, sir. What is the principle behind using amyloblastoma?
Not similar cells, Madhu. It's actually because you need a depth of destruction of bone. So 2 millimeters is, you need a sub-centimeter, minimum sub-centimeter margin of destruction of bone on all sides of the amyloblastoma. So this serves the purpose very well. Not very well, to a certain extent. It doesn't go 5 millimeters, but it does go 2 or 3 millimeters. So that's better than nothing, isn't it?
Okay, sir. And then the last question they've asked is, upon enucleation, after how much time bone forms, and when does it appear on radiograph?
It depends on the age. In young children, it forms very fast. Within 3-4 months, the bone forms almost to the crest. And for 5 months, maximum 6 months. Older people, it takes a little longer, but usually bone forms within about 6-7 months. It's significant amount of bone forms, yes.
Thank you, sir. I think you've taken all the questions. Both Muthusekhar sir and George sir, you've been wonderful mentors. You've taken every single question that's been asked online and even before. Thanks a lot, sirs. And thank you, Balaguhan sir, for being a wonderful moderator.
Thank you very much.
And Jimson sir, the best host that we can have.
Yeah. So let me give my formal vote of thanks.
Sure,
to Rina and Jimson for having thought of this extremely nice teaching program. To Muthusekhar, the speaker before me, who was a tough act to beat. He was very coolly answering the whole thing with absolutely no emotion. And Gohan, thank you very much for having done an extremely good job of moderating it, and Madhulakshmi for having invited me and to do the session, and for coordinating between me, Gohan, Muthusekhar, and everybody else. Thank you very much. And most of all, to all those who stood by and listened to this whole thing, and I hope it was useful. You can always contact me by my email or telephone or whatever it is if you have any more doubts about these topics. I'm sure Muthusekhar also is willing to do that.
Thanks, Raj. Thank you. Same thing. They can contact me also. Always there too.
Thank you, sir. Thank you all of
Thanks a lot.
the mentors and moderator. Now, for the participants, I would be sharing your link for the questions.
Can we leave now? Is that okay?
Yes, sir.
Thank you.
Right, okay.
Thank you, sir.
Thank you, Muthusekhar sir. Thank you, George Paul sir, and
thanks, Jimson.
Balaguhan. Thank you.
Return back soon. See you back in 10 minutes.
Yes, sir. Thank you, sir. Thank you.
Thank you, sir. For the participants, I would be sharing your link, and you'll have 5 to 7 minutes to answer the questions to the link. Jimson sir, shall I share it?
Yeah. please share it in that WhatsApp also, so that I can share it in Facebook live.
Sure, sir. I think everyone's got the link. You'll have 5 to 7 minutes to answer your questions. So I've shared some.
Yeah. The link is shared in Facebook Live as well.
So we can close it, sir.
Yeah, 2 more minutes because I think there was some issue in Facebook. Few of them were not able to access it.
Okay, sir. We are ready, sir. When you give us instructions, we can close, sir.
I think 1 more minute.
All right, sir. And if participants are still listening, George Paul, sir, has taken the effort to find out the answer for the steroid injections. He says steroid injections is an anti-sarcoid-like activity, as some thought that these giant cells were serious-like lesions. So it's basically the anti-sarcoid activity, the rationale behind using steroids for giant cell lesions. Thank you, George, sir, for taking that effort and utmost professional commitment to tell the answers to us.
Yeah, I think.
We close, sir.
Yeah.
And you want me to put the result here, sir?
No.
Okay.
This is for certification. Yeah.
Okay. So I think we've closed the session, sir.
Yeah.
Shall we?
We are on Wednesday.
Okay, sir.
Yeah. Thank you.
Thank you,
we'll
sir.
close the session. Yeah.
We close the session. See you all on Wednesday, 8 o'clock. Thank you. Thank you, sir.